J'ai vraiment le plaisir de vous présenter le professeur Giorgio PERILONGO et de saluer la présence parmi nous de Madame PERILONGO qui dirige à Padua un laboratoire de biologie moléculaire, si j'ai bien retenu. Il est né en 1955, docteur en médecine de Padua en 1980 avec full grades and knowledge, je suppose que ça veut dire la plus grande distinction. Il s'est spécialisé en pédiatrie à l'université de Padua, 80-84, puis en oncologie pédiatrique. D'abord à Padua, puis pendant 3, 4, 5 ans au General Hospital de Philadelphie, en greffe médulaire, oncologie et neuro-oncologie pédiatrique. Il est actuellement professeur ordinaire de pédiatrie à l'université de Padua depuis 2005 et il est chef du département pédiatrie et du département mère-enfant. Son activité scientifique, tant expérimentale que clinique, s'est concentrée sur l'oncologie, particulièrement les tumeurs malignes du foie, dont il est un expert internationalement reconnu, et sur les tumeurs cérébrales. Il est président du comité scientifique de la Société internationale d'oncologie pédiatrique et il vient d'en être élu président pour 2014 à 2016 et au sein de la CIOP, Société internationale d'oncologie pédiatrique. Il a été le coprésident d'un sous-comité de recherche sur le gliome cérébral. Alors, il a été le président fondateur de CIOPEL. CIOPEL, c'est une section de la CIOP qui s'occupe des tumeurs du foie. Et c'est dans cette instance que j'ai connu Giorgio PERILONGO, où j'ai apprécié son leadership, sa créativité, sa rigueur et son enthousiasme. Il vous décrirait les contributions cardinales de CIOPEL aux essais thérapeutiques contrôlés et les divers protocoles de chimiothérapie pour les tumeurs malignes du foie, en particulier Hepatoblastoma sur lequel il concentrera son exposé, et il vous en donnera les raisons. Et au nom de CIOPEL, il a signé ou co-signé une bonne dizaine d'articles dans des journaux de très haut niveau qui ont marqué des étapes importantes dans ce domaine. Alors, personnellement, j'ai depuis longtemps un intérêt pour les tumeurs du foie et dans ma préoccupation, je vous ai rappelé tout à l'heure, de promouvoir les disciplines pédiatriques, je souhaitais un orateur de grand renom pour parler d'oncologie pédiatrique. Dear Giorgio, I'm deeply grateful to you to have accepted my invitation and I invite you to take the floor to speak about the journey through pediatric oncology.
That's right. Okay. Morning, everybody. I do apologize. I will not be able to speak in French, so please accept that I will speak English. I am deeply honored to be here, and I really thank you tremendously, Jean-Bernard, to put me in such a difficult, actually, position to give this talk in front of this audience, but I'm pleased to do that. Okay, let me start. First of all, the journey through pediatric solid tumors starts saying that actually, as expected, as known, the pediatric solid tumor encompasses a variety of tumors, which, by the way, are totally different from the types of tumor that we see in the adult populations. Meaning, in terms of solid tumor, the brain tumor is the most common one, and going down to other series of tumor. And as you see, carcinoma is actually very rare in the pediatric tumors, becoming a bit more frequent in the adolescents and young adult series. The outcome of pediatric solid tumor in the last 6 decades has improved dramatically, as you can see or deduct from these slides, where you can see the mortality rate for childhood cancer, for solid tumor actually in cancer, at the beginning of the middle of the 50s were on the 80%, and now we are down in terms of mortality rate to about 20%. So what I will be trying to do during my talk is to bring you through the journey which brought to this incredible success that we have had in pediatric oncology. Before doing that, allow me, however, to remind you that cancer remained the first cause of death in children and young adults. So, yes, we have done tremendous progress in particularly in comparison with the adults. But there is still a lot to do in terms of reducing the fact that cancer is the leading cause of death in children. As you may have heard from the very nice introduction that Jean Bernard made, my field of interest has been two things, the brain and the liver. What I have decided to do is to bring you through this journey using the liver model, thinking and assuming that is a sort of a paradigm for all the progress, for all the steps which took place during these decades and which ultimately brought to the success that I pointed out. So I will do this journey with you using what I've called the hepatoblastoma model. Let me briefly say what is hepatoblastoma. It is the most, let us say, most common cancer, is actually the malignant tumors of the liver in children, is exceedingly rare, about 1% of all childhood cancer, is probably derived from a derangement of the normal mechanisms which bring to the normal hepatic development. There are associated conditions. I don't want to enter into the clinical disease, just to start this journey. I use also the hepatoblastoma model because the sort of common denominator that we pediatric oncologists are dealing with is the fact that we're dealing with rare tumors, no matter what. Even leukemia is a rare tumor. So in describing to you the journey, you will see that we will be talking about how to run research in rare diseases, in this case in rare tumors. Let's start. Well, you probably haven't pointed out, but the curve of the mortality rate for childhood cancer started to drop in the 60s. And the journey for pediatric oncology, as I guess it was for the adult tumor, I'm sure it was for adult tumor, started in the operative bed. Everything started from the surgeon who tried to get out of this tumor. Well, the first historical series that I was able to trace down from the literature dating in the 1971, reporting a series of patients treating actually in the late 60s. It was from Dr. Howard, who was working in England, and he reports about 19 infants and children treated for hepatic tumors. And what they come out with only 3 survivors for more than 1 year. So still a very poor outcome for this tumor, with quite a lot of intraoperative death, mostly due to hemorrhage. Well, we had to wait until the 70s to have the chemotherapy entry into the armamentarium-treated pediatric tumors, actually to treat hepatoblastoma. Indeed, at least for other tumors, pediatric solid tumor, mostly Wilms tumor, the introduction of chemotherapy in the armamentarium to this tumor started a bit earlier. But following the hepatoblastoma model, we can say that it was in the 70s that the first time after surgery chemotherapy was systematically used. And this actually is the first report describing a series of children with hepatoblastoma treated with surgery and followed by chemotherapy. But as you can see also in this series, the survival rate was quite disappointing. Those 2 lines indicate 2 different studies, run after the others, but once again you see the survival rate was pretty poor, with about 30% survival at 5 years. However, behind this literally almost no progress, something major happened behind the scene, and those are the 2 things which happened. The first of all, the concept that we can hope to cure pediatric solid tumor if there is a multidisciplinary pediatric oncology team. So in the early 70s, let us say, we saw all around the world, in some center of the world, the beginning of the multidisciplinary pediatric oncology team. Just looking slightly back in the past, I'd like to remember that it was in 1952, he died in Paris, Odile Schweizgut, the founding mother of the International Society of Pediatric Oncology, put together 16 beds just to treat children with cancer. And as it was said, it was in 1958, that at the Harvard Medical School, Dr. Damjed Evans described that 2 young pediatric oncologists started to use the drugs in solid tumor, Wilms tumor, and it was in 1962 that it was opened the first hospital exclusively dedicated to treat children with cancer, which was the St. Jude Children's Hospital in Memphis. The other thing that happened that we pediatric oncologists realized that having to deal with rare tumors, we could do significant progress only pulling together the data. So the 70s marked the beginning of what are called the cooperative childhood cancer study groups, which allow, as I said, to put together a decent series of patients, which allow consequently to run significant clinical trials, and first of all, prospective clinical trials. So behind the scene of the first trial using chemotherapy along with surgery, there are two major events: the constitution multidisciplinary oncology team and the constitution of child cancer study groups. Let me go back briefly on those studies that I mentioned to you. No significant benefit, but there was an evidence. In the first study, 11 children were treated with surgery alone and 7 relapsed. In the second study, the one with the dot lines, they used chemotherapy, and out of 16, only 1 relapsed. So that was the evidence that chemotherapy can do something for this tumor and foster the enthusiasm to move forward looking for new drugs. So making quite big jump in a short period of time, in the 80s, a magic drug, I call it magic quote unquote, came into scene, which was the cisplatin. At that time was a new drug, a platinum-derived drug, which allowed to document this event. There's such a big tumor, that is a big hepatoblastoma, involving almost the entire liver, at least all the right and a bit of the left. Treated with chemotherapy, it was becoming smaller. There was a fantastic evidence that the chemotherapy can actually reduce the tumor volume and making the tumor more likely to be completely and safely resected. And actually this evidence really fostered major enthusiasm and brought to the 90s, where there was the booming of clinical research pretty much in all solid tumors, but I will still use the hepatoblastoma model to describe this booming of clinical research, which for the hepatoblastoma was called the cisplatin area. And the result that I will now present to you to bring you through this journey come essentially from the result of 2 major study groups: the American Intergroup Hepatoblastoma study and the COPEL group, which was the European group which ran the research on hepatoblastoma, and of whom Jean Bernard has been one of the founder and the leader figure. Well, those are the survival which were then produced, introducing this magic bullet, cisplatin, in the treatment of hepatoblastoma. If you remember, in the first slide I showed you the survival curve, which was on the 30%. Now the curve jumped into a more than 60% survival. It was a randomized study. I don't want to enter into detail of this study, but just to show the survival really jumped, made a progress both in America and in Europe. Those are the study coming out from the COPEL study, the trial we put together centers coming from the European Center. So the bottom line, the booming of the clinical research, the 19, is marked by the fact that using these new drugs, cisplatin, we were able to double the survival of these patients. One of the other things that emerged during these ages that it was true for hepatoblastoma, was true throughout pediatric solid tumors, that pretty much there were different treatment philosophy between the major cooperative groups, mainly the Americans and the European, and it was not that easy to understand each other. It was almost if we were speaking different language. What am I referring to? I'm referring, and I use the hepatoblastoma model, but it is the same for the Wilms tumor model, which is Wilms, by the way, is the tumor coming out from the kidney. The Americans were using this approach, having the child come into the clinic, big tumor, go to the emergency room, take the tumor out, and then do the rest. And so they were describing this tumor according to the concept of staging. So describe what is left after surgery. So they were talking about stage 1, meaning tumor completely resected, stage 2, tumor almost completely resected, and so on and so on. Once again, they were talking about staging in presenting our data, their data, and instead in Europe, we were talking about different language in the sense. we were using a different philosophy, which was to have a child come into clinic, big tumors, not to bring him to the operating room, but to treat him with chemotherapy, because we know the chemotherapy could make the tumor smaller, more easy to resect, more likely to be completely resected, and then bring him to the operating room only after this course of preoperative chemotherapy. So we in Europe face the problem, can we describe the tumor before actually the surgeon go bring the child to the operating room and take it out? So we were looking for a system which could describe tumor extension before surgical act. Actually, and the idea was to respect the anatomy of the liver and particularly the structure of the hepatic veins. Bottom line, we came up with another system to describe tumor extension, which was called the pretext. Once again, I don't want to enter into detail to focus on the issue of a common language that we're missing at that time. And the pretext system will describe the tumor extension according to how many sectors of the liver the tumor was involved in, 1, 2, 3, or 4. And that was the concept. So the bottom line, I don't want to enter too much into detail, but we found out that both the Americans were talking about the staging, so trying to describe the outcome based on the results of surgery. We were bringing our result to the table, talking about tumor extension and presentation. There was a problem. We could understand each other. A major effort took place at that time, and just to bring it to a conclusion, as of now, the pretext system, the system which allowed to describe tumor before the surgeon take it out, has become the common language that we're using. And to have a common language opened a new area of exchanging data and of talking to each other. What also happened in the 90s that we start to understand, and that once again was true for almost all solid tumors in children, that what we call children with hepatoblastoma are indeed an heterogeneous group of patients in terms of prognosis. So the 90s marks the beginning of what has been the further subclassification of patients into risk category. I will be brief. The Americans came out with this concept, which is universally accepted, that children with stage 2 and 1 mean those patients for whom the surgeon can take the entire liver out have an excellent survival, almost 80%, over 90%. The one, particularly the one where the tumor cannot be taken out and the one presented with metastasis, those mean stage 3 and stage 4, have a much worse prognosis. Actually, they come out also with another evidence, which I like to remark, because they actually signed a new finding, that they also find out a subset of patients, the one who have the tumor completely resected and especially histology, who can do well with minimal therapy, if actually no therapy at the moment. So anyhow, just to give a sense of what means splitting the tumor, the cohort of patients in subgroup of risk, according to risk categories, the American came out with 3 risk groups, which of course influenced the way we would have run the clinical trial afterwards. And just to highlight to you how the problem of understanding each other came along, this system was not accepted in Europe because we were going through a different direction. Once again, we were using the pretext system, the one that I mentioned to you, which described how many sectors the tumor involved, and we come out with the idea that what is more important in terms of prognosis is the amount of sectors of the liver that the tumor involved. If it involves only one, excellent prognosis. If it involves all 4, very poor prognosis. And also we confirmed that children with metastasis, mainly lung, have a very poor outcome. So bottom line, different from the Americans, we come out with 2 staging systems, with 2 risk categorization, one called standard, meaning tumor involving only at the most hepatic sector and most hepatic disease, and all the others. Once again, no detail, but just the concept how difficult it was to actually talk to each other. Yes, we came up with a common language in terms of describing tumor extension, but we didn't come up together in terms of risk stratification. Looking for a risk analysis, also we find out that those children who present with hepatoblastoma with the low alpha-fetoprotein, what I'm talking about, children with hepatoblastoma have a biological marker of a disease which is the alpha-fetoprotein. It's the fetal albumin, which those immature cells continue to produce even during postnatal life. Well, usually the vast majority of children with hepatoblastoma have a sky-high level of alpha-fetoprotein, but there are a few of them who are very low level, and those who are a tremendous poor prognosis. We know that behind this tumor there is a special subtype of hepatoblastoma, which I will be talking very soon. For the one who are familiar with the adult oncology, you know that how much also histology can influence prognosis, also how histology can be used in creating cluster of patients according to risk category. Well, for pediatric solid tumor, during this journey which brought up to the result that you have seen, for some tumors definitely we came up with what was called favorable and unfavorable histology. That was true for the Wilms tumor. That also was true for rhabdomyosarcoma, the malignant tumor coming out from the muscle in children. For hepatoblastoma it was not clear. Yes, we came out with this subtype called small cell undifferentiated hepatoblastoma, and for which we know that survival is very poor. There is a relatively recent collection data in 2009 of this rare subtype of hepatoblastoma, of which none of them survive, regardless of the stage. So actually, in terms of risk categorization and on characteristic to create this risk group, also the rare variety of hepatoblastoma came along. I don't want to say too many details, but these variety actually overlap, sorry, just a little technical detail, for very specialists, that overlap with another rare tumors in children, which is called rhabdoid tumor, which has a sort of a genetic hallmark, which is the homozygote deletion in the 22q12 regions where this INM1 gene is located. So now for us the problem when we run into these patients with the hepatoblastoma and low alpha-fetoprotein to make sure that we are not running into this rare variety. But the 90s also marked during the booming of these, of the clinical research on hepatoblastoma, marked the fact that it was clearly shown that orthotopic liver transplant can be a curative tool for children with unresectable hepatoblastoma. And that is the fact. Well, what was the concept behind? The concept behind that only those children who can have the tumor completely removed can hope for cure. The other are not curable. And also we know that systemic chemotherapy, cisplatin, can bring to a great outcome. So the idea was why not to use transplant for those children who has a non-resectable tumor. Well, I need to say, and not because I'm here, that the landmark paper which pointed out the role of liver transplant in hepatoblastoma came out from Jean-Bernard Hotte, who actually put together his experience. He raised up the phone, he called up all his colleagues around the world and put together the largest series ever published at that time on orthotopic liver transplant in hepatoblastoma. And I want to mention, you listen to the citation, that the paper that Jean-Bernard wrote in 2004 was for many years the most cited paper on solid tumors in children. Very interesting. But bottom line, what Jean-Bernard showed, making his collection, that the survival of those children who had a tumor not resectable with conventional surgery could be treated with orthotopic transplantation and could enjoy a very good survival. So the message was transplant works. He's also showing another interesting point, that particularly if you use as a first-line therapy, not as a rescue treatment, and not after the child has relapsed, but when you have finished your chemotherapy and you say, God, what are we going to do? Are we going to resect? No, it's not resectable. Do we leave the child die? No. Let's do the transplant. If you do the transplant at that time, the survival can be particularly positive. Many data being collected about the role of transplant on hepatoblastoma, and I can't go over all those because otherwise I will take all the time I have. But I just want to mention a very recent series which has been published this year, coming out from Pittsburgh, one of the leading institutions in transplant, which showed that the number of transplants for hepatoblastoma has increased steadily during the years, reaching a top level in this year. Here, I don't know why they come up with so low, but that's the data. And once again, they produced, combining their own experience with all the other series they collected, excellent outcome data. And once again, confirming the data that Jean Bernard has produced many years ago. In this sense, I also want to remember that it was thanks to the work that Jean Bernard did and thanks to his commitment that Jean Bernard did worldwide registry on children transplanted for a malignant tumor being put up and is still going on and is becoming a very important source of information. 2000. The year to the beginning of the new century, I must say, didn't see a significant progress in terms of prognosis. We end up in a sort of a plateau. But what the year 2000 allowed to do was to refine therapy according to the risk category. I will be short in order not to annoy you with technical information. But just to mention the most, what we think are the most significant contribution coming out from the clinical research in terms of refining therapy came out from the COPL group. Well, bottom line is so-called standard risk. You remember, the one with a favorable outcome. We decided to run the randomized study comparing, I don't want to enter in detail, but just want to mention comparing the historical regimen, which is called PLATO, 2 drugs, with just one single drug, cisplatin. And those were the results. Sorry, I mentioned that it was a really fantastic success. And what we come out, that with minimal therapy for a selected group of patients, we can say, well, they can be almost cured. We reached this 90% survival. Also for the high-risk patient, the one where conventional surgery could not be done and the one presented with metastasis, we decided what to do. Well, is to still use this magic bullet, means cisplatin, more aggressively, weekly. Once again, details that I don't want, that are probably too much, but to use as much as toxically possible cisplatin, and we come out with this excellent result. And also for the high-risk patient, we only reached the 80% survival, so an excellent result. The most significant result was in patients with metastasis, for whom we had projected at 2 years, now has been confirmed 3 years survival on 77%. So comparing with, these historical data, which were studied from 28% for children with metastasis in terms of survival, now we are on the 77%. So great success in terms of refining therapy. I should not neglect my American friend. Sorry, let me do one step. Sorry, I jumped too much. I haven't mentioned that behind this, of course, there are toxic problems. Cisplatin is particularly toxic for the hearing. It can make the children deaf. And that is one of the aspects that is all behind pediatric hematology oncology, and the effort that we do is, yes, to try to improve the success in terms of outcome without having the patient to pay an exceedingly too high price in terms of toxicity. In terms of refining therapy, I should not neglect my American colleagues, otherwise they can be upset to say they also contribute significantly in refining therapy for these patients. And once again, no detail, but their contribution was mainly in the very favorable subgroup where they show that actually there are very selected group of patients we can be treated with surgery and nothing else, or with surgery and very little chemotherapy, as we have shown. Where are we going? I'm almost at the end, but I have a surprise at the end. Anticipated I have a surprise, Jean Bernard. Okay, but let me finish the journey. So 2010. Well, the 2010 marked the fact that we are facing a problem. We are splitting patients according to smaller and more risk categories, and we run into the problem how to run clinical trials in smaller and smaller group of patients. So the 2010 signed the beginning of the worldwide cooperation, no more 2 groups, just one big group. And the mark is the SHIC project. What is the SHIC project? Well, we started with the idea of pulling together all the data coming from all the studies that we have run so far in America and around the world, And this is what is the chic. This is my friend Piero Chaderna, who represents the European group. This is Rebecca Meyer, a pediatric surgeon from Salt Lake City, who represents all the American group. And he's the representative of the Japanese group. Well, we decided to put together, and then when we assigned this contract, this project, to put together the data in order to analyze a tremendous amount of patients. You remember how rare were these tumors? Well, we come out with 1,600 patients. That for us is just a huge amount of hepatoblastoma and a huge source of data to investigate more accurately some clinical characteristics like the prognostic factor. And once, I don't want you to go into, I will not present you these busy slides, but I just want to present that running this analysis, we come out with a very sophisticated prognostic group. What is behind? Behind is the new future of therapy, which is to move towards a personalized clinical approach in order to understand for each patient, for each tumor, what is the best approach. What I have not described in this journey, well, what I have not described that insofar as hepatoblastoma, we still have little clue on the intimate biological mechanism underlying hepatoblastoma development. Well, we know that, as I said, that probably hepatoblastoma derived from a derangement in the normal mechanisms which bring to the normal liver. Means that some cells, instead of becoming adults, hepatic cells, remain embryonal, maintain stem cell characteristics, like the fact of having to be immortal, to continue grow, of invading the surrounding tissue. And maybe those cells acquire also some genetic characteristics which make them even more malignant. Well, different from other adult and pediatric cancer, for which we know some of those mechanisms. For hepatoblastoma, we still have another clue, which means that we have not been able to develop the new biological-driven target therapies. Here I am at the end. By pursuing, and I think that I should do that, I have decided not to finish my talk here. I do a little detour and tell you something. I go. I start like this. Shakespeare already said in one of the major comedy that Padua was a nursery of art. And indeed, I think it is universally acknowledged that the University of Padua played an extraordinary role in promoting science, at least in the 15th and 16th century. Just for you to know, my university was founded on September 29th of 2022. The second oldest university in the world, still active after Bologna. This is our university now. I hope some of you have already seen or will have the chance to see. Well, bottom line, one of the major players who actually allowed to do progress in medicine was someone coming from Brussels. His name was Andrea Vesalius, who actually came and taught at the university and was nominated for professor of medicine when he was only 23. What was his contribution? He separated two words, the medieval and the modern way of conceiving medicine. I guess some of you already know, and I hope not to offend you in remind you this fact. But what I mean by that? Well, you know that at that time, the science for improving our knowledge in the world of medicine was just to do body dissection. Before Vesalio, how were the anatomy lesson done? Well, there was a lecturer who was standing up in his podium, reading the book from Avicello, from Galenus. And then there was the man who was cutting the body, the sectors, and there was the ostensor, which was explaining how what is written in the book actually happened in the body. So the idea was, let's read the book first, and then find out it is true, not vice versa. What Vesalio does, Vesalio gets up from the podium, from the chair, picks up the knife, and go down himself to cut and see And he's decided no more deduction for what Galeno and Apicella say, but let's see what it is and let's rewrite the books. And that's what he does. Here is Vesalio, which gets up from the podium, gets attached to the body, he cuts the body, he sees, and he describes. No more Galeno, no more Apicella. Actually, that was the change of the way science was conceived. At that time, also Copernicus was actually publishing his book on with the tremendous hypothesis that probably is actually the planet turning around the body, the sun. And what I want to finish up is that Vesalio, for 16 years, he worked really day and night in doing body dissection. He came to Padua actually because body was available. And there is another story behind here, but I can't tell you because otherwise I will lose too much time. Well, however, in cooperation with an artist, John Stefan van Galkar, who was actually a student from Titian, he published a landmark book in the anatomy, which was called the Humani Corporis Fabrica, containing over 1,000 of these kind of pictures. Look how beautiful, how detailed are these pictures coming from Andrea Vesalio. Here describing muscles and the body. Here describing the nerves and the skeleton. Here the brains, fascinating picture because they couldn't fix the brain at that time. So those are just fascinating picture. Muscles again. And that is interesting how at that point arts and scientific description were influencing each other. Here from Vesalio describing the skin. And here the Sistine Chapel, Michelangelo talking about a body without a soul. And once again, art, history, but we are matching together. This is Vesalio, who actually definitely took inspiration from a Roman statue, from a female and from a man body. And also how the first picture influenced art. Do you remember this is Vesalio doing surgery, and you see this is a print, a masterpiece from Donatello, which is describing a miracle, and you see there are the same concept. Here Mantegna is using the same view that they were using to describing Vesalio during his body dissection. So pretty much Vesalio reached the conclusion. Now I go back to the story. The Galeno anatomy was not reflecting human anatomy, but was actually a deduction probably from some animal, mostly monkey. And actually he opened a new story of the anatomy, which brought later on in the century to build the anatomical theater of Padua, and ultimately brought to the work that Gianni Battista Morgagni did actually much in a couple of centuries later, founding the anatomy pathology. It is really a great honor for me to lecture you today, and do thank you a lot.